Hi, everybody. Eric's not going to be with us this afternoon. I'm Kathy Andreessen. I work here in the trauma program at Maine Health. And if you can, please put your name and license number in the chat. Hi there. For those who are just joining, I'm Kathy Andreessen. Eric's not going to be able to be with us this morning or this afternoon. So if you haven't already, please put your name and license number in the chat. If you're watching as a group, you can put them all together in one chat window. That'd be great. And Dr. Shurtleff will be joining us shortly. Thanks very much. Nice to see everybody on this afternoon. If you've just logged in and you haven't already, please put your name, first and last name in the chat with your license number so we can keep track of who's here and make sure you get your continuing education credits. Eric's not going to be with us this afternoon. So I'm Kathy Andreessen. I work for the trauma program and I'll be here doing the administrative task. For Dr. Shurtleff, log on.
Yeah.
Hang on. Hi, everybody. We're going to get started in just a few minutes. If you haven't already, please put your first and last name in the chat with your license number so we can make sure you get your continuing education credits. And we'll be starting in just a few minutes. We'll give people just a few more minutes to log in.
And then here we go. I'm here. Hi all. Where is here we go.
Hi, Dr. Shurtleff.
Hi. Hey, how's it going, Kathy? Long time no see.
I know.
Let me get this thing pulled up and get it shared. Okay. Do you see this screen?
No, I just see your smiling face.
Okay. I'm working on it. Hold on. Let's see here. Share button over here.
I'm coming in just a moment.
How about now?
Looking promising. Yep. You just gotta go, you gotta enlarge it in full screen, your slideshow.
Yep. So that should be good to go. You guys seeing the screen out there?
So you're not enlarged all the way.
Okay, can you hear me and can you see the screen? Oh, all sorts of thumbs up. Awesome sauce. Okay.
I can hear you.
Oh, hi, Eric. I heard a rumor you weren't gonna. I typically, let me see. Sometimes the slideshow advances. Okay, thanks. Bye. Okay. Can you see the cursor? Can you see a cursor at all? How about now? Laser pointer? I can't. Kathy, can you tell me what you guys can see? Kathy, Eric, somebody?
Yeah, we can see your slides, but you're still in
Presenter view.
in presenter view in PowerPoint.
Really?
Yeah.
I'm not really
It's
sure.
because
How
you
about
have
now?
two screen, it's because you have, yep, that's good. Now just start your slideshow from the beginning and we should be all set.
I did that. That's what I did, and then it went into something that
Yeah,
I
click
don't
what-
know how to change this over. And I
It's-
kind of don't think it matters too much.
I think if you just go up on top where the second over from the left where it says display
Yeah.
settings.
Okay.
Yes, so
Let's try
swap
that.
prevent.
There
There
you
you go.
Can
Okay.
you see?
Now we got
Can
it.
you see a cursor
Looking good.
here?
Yes. Great.
You
Yep.
can see my cursor moving around.
I can. Yep.
Perfect. Okay. Thank you for bearing with us for all of the technical learning that I'm doing. One day I'll have it figured out.
That's okay. These things happen.
So it's good to have people that can help. Um, so if you haven't seen one of these before, my name's Eric Shurtleff. I'm one of the trauma surgeons at Maine Medical Center. And every month we do a talk about traumatic injuries, and talk about some of the field management techniques and why that matters. And this is sort of a interesting one in that the main things, the most important things to do in the field are things that we continue on in the hospital and in the ICU. And so these cases give me a chance to sort of show the whole continuum of care from the time of injury all the way through to 6 months out after discharge. And so hopefully this is this is interesting to you all, and I just want to say thanks very much for making the time, and I'll get rolling. Oh, I guess one more thing. In case there's folks that haven't been on these before too, I am the EMS trauma liaison for the group, and so if there are cases that you have an interest in getting, more real-time feedback, as in like within the same day or two or week of an injured patient that you brought here, please ask your chief to contact me. My email is there at the bottom. It's actually misspelled. There's an E in here, but also Julie knows how to find me, and I think I've spoken with. I'm on a fairly familiar basis with a lot of the chiefs down in this area of the state. So at any rate, if there are patients that you're curious about, please have your chief contact me. Okay, so without further ado, let's talk about traumatic brain injury, neurocritical care, both in the pre-hospital setting and the ICU. Basic things that we'll be talking about here are really kind of identifying and stratifying traumatic brain injury in the field, specifically like what's a moderate and what's a severe. This is a lot of this is going to be a review, especially the first part of the lecture. I'll just warn you. But it's good, I think, to go back through some of the protocols and bring out some of the important points within them. Understanding
Eric,
of been a critical error.
I'm sorry to
I'm sorry.
interrupt you. We lost your slide. We lost the slide view again.
Really?
Yes.
I don't know what to tell you. I think we've had this problem in the past, and so what I'm going to do. Sorry, everyone.
Well, that's okay. I think it's just the
No, I think I'm just making it more complicated than it has to be. What I'm going to do is I'm just going to go from here. If you guys don't mind looking at a little bit of stuff on the exercise, I never have a problem when I present this way. So can everyone see the slides?
Nope.
You
I
can't
lost
see
them. I
slides
had
at
them a
all.
minute ago.
Okay, hold on. This is so frustrating. Okay,
I don't see your slides, Eric.
I know. These. All right, do y'all see my desktop now?
Yes.
Okay. I don't have it. I didn't even touch anything. Now do you see a PowerPoint?
Yes.
Yes.
Great. Well, I'm just not going to mess with the slideshow part. I'm going to correct this. So that is my email address. Please feel free to email me with questions and I can respond to your chief. That's just the way we share information. Without further ado, okay, learning objectives. Here are the basic things that we'll talk about. Understanding and implementing critical airway and oxygenation interventions, in addition to once we've identified, yes, this is a moderate to severe TBI. Understanding critical hemodynamic support, traumatic brain injury, and why these things are important. Discuss the pearls of prehospital traumatic brain injury care. And then this sort of gives a jumping off point to talk about the patients once they're here and some of the things that we're doing in terms of ongoing research and clinical trials. And I will get into that at the end of the lecture. So starting really basic, this is the Glasgow Coma score. The reason I even put this here, I know you all are very familiar with this, is that it is very important to have an accurate score and the best score from the field. But in general, everyone is quite facile with this. The best motor response really is what correlates best with clinical outcomes still, even after all these years of research and all of the millions of dollars in time and energy has been put into it, it still is sort of the benchmark that we measure outcomes with. And I just wanted to draw your attention up here. Moderate to traumatic. Moderate is classified as a GCS of 12 to 9. And then severe is 3 to 8. And it's really the severe traumatic brain injury folks that we tend to have the most work to do with. And if there is a chance for salvage, those folks go through a very sort of intensive gauntlet in the ICU. And I'll talk about that here in a little bit. So these are really the just examples of the very basic traumatic brain injury patterns that we see. And so this is an epidural, which is typically hemorrhage from the middle meningeal artery, which is just outside the dural sac. And so it tends to push inward. So this is high pressure blood here, and it pushes the brain inward. The dura will form this characteristic lenticuliform because it looks like a lens, or a convex brain compression. So this is an anterior branch off the middle meningeal, which is right here, which it's sort of a design flaw, but that is actually the thinnest part of the skull. That artery travels right beneath there. And unfortunately, if you get hit just right, it will trigger a bleeding situation like this. If you ask, well, let me hold on to that thought for a second. This is a subdural hemorrhage, and you can see that the subdural hemorrhage kind of organizes all the way along the hemisphere. It's called hollow hemispheric. This is typical of a subdural hematoma, and you'll see this much more commonly in older folks. As the brain shrinks with age or atrophies with age, it stretches the bridging veins between the dural venous sinuses that carry the deoxygenated blood off of the brain and the brain itself. So as you can imagine, there's these bridging veins between the hemisphere itself and the dura. And as those things stretch, if you have if you have a shearing force on the brain where the skull stops but the brain keeps going because it has space to move, then you will get tearing in these veins. And so it's a lower pressure hemorrhage, but it sits right on top of the brain. It's subdural. And if you ask a neurosurgeon which one they'd rather work on, it's the epidural that they would rather fix. And there's a lot of reasons for that, but the one of the main ones is that as this blood sits on the brain, it triggers inflammatory response. It triggers um, changes in the metabolism of those neurons, and it stresses the entire injured brain itself. And they're also more likely to have underlying brain injury as well, where the tissue itself is injured. Um, C is contusions, and so what these are is bleeding within the tissue of the brain. And that's bad. That's hard to fix. We call these extraaxial, these two, the epidural and the subdural, because these can be evacuated. The skull can be taken off, the blood can be removed, the brain can re-expand. Here, these will tend to trigger seizures, which increase the metabolic rate of the brain, and directly affect the ability of the neurons in these areas to do their work and transmit. And as you can imagine, bilateral frontal intraparenchymal hemorrhage is gonna be really a devastating injury. And then this one is this is here. There's some shift here, and there's bleeding again in the parenchyma. And then there's also blood in the ventricles. You can see these are the lateral posterior horns of the of the ventricles, and you can see blood filling in there. In general, on a CT scan, I probably should have said this at the beginning of this slide, but the brighter stuff is acute blood. And then the darker stuff is clearer, less dense fluid. So these are the ventricles here. And this thing here is called the midline falx, which divides the two hemispheres of the brain. So that's a some basic example of the types of traumatic brain injuries that patients have. And one of the cases here, the patient has all three of these. Something to remember too, and I think a lot of the bad scalp injuries that we see here, there's really careful attention taken to make sure that we have good pressure bandaging and good when the patients get here, typically there is some sort of hemostatic pressure dressing on these injuries, and the crews for the most part will say like, hey, yeah, there was about a liter or two on the ground. But I mean, the point of it is all of the blood supply between the skin and the skull, all the blood supply is between the skin and the skull. So there's arteries here, there's veins, there's muscle tissue, there's all of this very well perfused stuff up here with multiple arteries leading to it. And so you can lose a lot of blood from a scalp wound. In fact, I've had to start MTP for patients with scalp lacerations. In like an open skull fracture. That patient, it wasn't in Maine, this was out in California, but the patient showed up in hemorrhagic shock from a head injury, an open head injury. So lots of blood loss here, really important to get the best control you can with pressure and dressing en route. And then we will oftentimes, as we wash out these wounds, we'll find the vessels that are bleeding and tie them off in the trauma bay itself, because the patient will become unstable if we try to go to some other part of the hospital, either a CT scanner or somewhere else. So these are the basics of traumatic brain injury management in the Maine state protocols, and I'll go through this relatively briefly. But pre-hospital moderate to severe traumatic brain injury should be sort of applied or just assumed in any patient with a physical trauma and a mechanism consistent with the potential to have an induced brain injury, and either loss of consciousness,
a GCS less than 15, decreased responsiveness, or any deterioration from the time you get to them while they're en route. And so I guess what that really means is always suspect it, have a very low threshold to react and to do the things we know that can influence outcomes. Um, it should be suspected in any multi-system trauma requiring a BVM or if we see post-traumatic seizures. At the EMT level, continuous pulse oximetry, monitor and reevaluate every 3 to 5 minutes. Systolic blood pressure is also critical. It really all brain comes down to oxygen and perfusion and the way those two things interact. And it is really, that is the thing that either makes or breaks somebody's functional outcome. And it begins from the moment of injury and it continues out to at least a year, honestly, is what we tend to discuss with patients' families. And that in terms of reaching a new functional baseline, it takes about a year. We're most of the way there by 6 months, which is why when I talk about the boost trial later, that's where we remeasure patients at that time frame. But in general, the damage or the rescue happens within the first 72 hours or so. I would say in most cases, immobilize the spine if you have concern for a head injury. In fact, in all cases, if there's concern for a head injury, immobilize the spine. In terms of elevating the bed to 30 degrees, it would be more keep the patient flat and maintain the spinal precaution, but try to get the head above the feet. And that's important for relieving or reducing intracranial pressure from a severe traumatic brain injury. High flow oxygen on all TBI cases, that's critical. And this is really the beginning of the critical care for that patient. Identify and treat any episode of hypoxia, which is we define as 90% SATs or less, or any evidence of cyanosis. If you have high flow, proceed to the if you're failing, proceed to the airway algorithm and continue to reevaluate. It's very important. And the reason for this is that we do know a single oxygen saturation level less than 90% is independently associated with at least a doubling of mortality in severe traumatic brain injury. So that's why we take it so seriously. Of course, that's much more difficult to do in the field than it is in the hospital. But just to really underscore the point that you really are beginning the neurocritical care for these patients at the moment you reach them, and that oxygen is priority number one. And really also priority number one is perfusion. So we'll talk about that here a little bit. I think this is all kind of basic rescue breathing or assisting ventilation, which is in the airway algorithm. And this is also a kind of a note to dispel some of the dogma that's come to us from the past. Hyperventilation actually is independently associated with doubling mortality. So the problem there is that when we hyperventilate patients and we depress the CO2 below normal, there is a compensatory vasoconstriction within the cerebral vasculature. So those small vessels that are in there trying to perfuse that injured brain they narrow if you induce hyperventilation and you drop the CO2 below 35%, or 35 millimeters. So there is really only one instance where we will still hyperventilate patients, and that's a tier 3 intervention on the way to a decompressive hemicraniectomy in the ICU. And even then, it really has not been shown to influence outcomes, but we do know it can cause harm. And so intentionally hyperventilating a patient is not indicated in severe brain injury. Obviously, hypoventilation is not great either. So in general, it's just proceed with normal rescue breathing per the algorithm, regardless if there's a TBI or not. And if obviously if there's airway compromise, hypoxia, airway management for the EMT paramedic. And then your end tidal CO2 goals are really dead center at 40. Basically, you're targeting a normal end tidal. And again, here we took pains to restate that it does not encourage any hyperventilation. And I know that that was in previous protocols, but it is no longer. We know that it can cause harm. Um, let's see here. I think this gets into basic blood pressure targets for pediatrics, systolics greater than 70, age greater than 10, it's greater than 90. And then essentially whatever you can do to maintain the systolic greater than 90 in adults and adolescents. And so that's volume resuscitation. If you have blood products available and this is a critical polytrauma, then yeah, that's the way to go. If you are moving quickly and have crystalloid, then that's the way to go. But really maintaining a blood pressure is also critical in traumatic brain injury because a single episode of hypotension is independently associated with at least a doubling of mortality again. So it really does boil down to blood pressure and oxygenation. In the context of head trauma, permissive hypotension is not something that you want to do. If the systolic is dropping, obviously communicate with us. But again, it's getting that volume resuscitated to the best of your ability while you're moving towards us. And these are just sort of the basics of what we've been talking about. It's just the algorithm itself. But I think all of this is pretty much self-explanatory from what we've talked about already. So, and in this case, so where you're in this case, it is so important that we'll actually, if you have the time, repeat the fluid bolus, try to get volume into the patient. I know we can be somewhat restrictive with crystalloid, but in these cases, the perfusion of the brain is so important that it's actually indicated to repeat a fluid bolus and route. Okay, to the cases. Any questions about that stuff? Kathy, is there anything showing up on the feed that I can answer?
Not yet.
Okay.
If anybody has a question, if you put it into the chat, we'll make sure that Dr. Shurtleff has a chance to answer that.
Okay. All right.
Oh,
So
wait, you got one question. See, we ask a question. So Brian asks, what are your thoughts on LR in TBI?
It won't harm. Normal saline is a better fluid for TBI, but it won't do harm. I think really the goal there is to restore normotension or get their blood pressure above 90. So it's essentially what you have there. Sometimes, like if we're getting this straight out of the field and all we have there is LR, that's not typical in the trauma bay. But if that were the situation, we would give the volume, and then when we had 3% or something else, we would give that on top of it. We do know that Normasol can cause problems, but in general, saline's the best for isolated TBI. LR will not do harm. You will have more harm done by hypotension than you will by LR, if that makes sense. So in that case, if that's all you have, give the volume and restore the blood pressure best you can. That makes sense. Anybody else?
All right, I think we can continue on, and
All right.
I'll keep an eye out.
Thanks. That's a good question. So this first case, it's a sad one, but it serves as a good learning opportunity
So we'll go through it, and I saved the better outcome for second. So this is an elderly female who had previously been admitted to another facility within the past month after a fall with a traumatic brain injury. Past medical history was significant for coronary artery disease, and she was on two agents, which really changed the game when it comes to TBI, Eliquis and Plavix. And she presented as a level 1 field trauma to our facility after an unwitnessed fall. She was found down the morning of presentation, and there was an unknown duration of time from when she was injured to when she was found. She did have a left frontal scalp laceration, and the blood was congealed by the time EMS got to her. And her initial GCS was 3, and the pupils were fixed at 4 to 5 millimeters. EMS intubated the patient by RSI in the field, and initially hemodynamics were labile. They ranged from 70 to 180, which can happen if someone is herniating. You can see these wild pressure fluctuations also, with induction medications that can happen, but was stabilized en route with IV fluids. So, from the time where she got unstable and they reacted quickly and resuscitated, they got her hemodynamically normal by the time she was to us, which wasn't over a huge period of time. So it was, overall very, very well managed. By the time patient reaches us, she's hemodynamically normal, well oxygenated by mechanical ventilation, but she's unresponsive. So, and the pupils are fixed and dilated. So this, even from the beginning, this is not sounding like it's going to end well. But I just do want to take a minute to say, like, the folks that took care of her in the field did absolutely everything possible to give her the best possible outcome. There's, they're just in going through the run sheets, like it was very, very well done. And it's just unfortunately, sometimes their patients aren't savable. So when we got her image, she had acute on chronic subdural hematoma with a 2 centimeter midline shift. The right ventricle was completely effaced, which just means it's collapsed. And then there was almost complete effacement of the basal cisterns, which is really ominous because that means the fluid can't drain in along its normal course. And kind of even worse than that, there was intraparenchymal hemorrhage in the midbrain, which is the pons and medulla. Again, bleeding in that location is that makes it very, very difficult to salvage a patient, especially someone who's older. There is this concept of neuroplasticity in younger patients, and I think that's really well demonstrated in the literature. And the truth is, a 25-year-old with this injury, well, maybe not this injury, but a 25-year-old and a 9-year-old with the equivalent injury do not have the same outcome, and it's a lot to do with the fact that the 25-year-old has neurons to burn and can really compensate for an injury, whereas, the 90-year-old cannot. There was a right humeral neck fracture. There were compression deformities, age indeterminate, possibly from the last fall. And then she had some anterior pelvic fractures and a left frontal scalp laceration. In talking about in talking about the signs of closed head injury here, you see the congealed kind of supraorbital blood on the supraorbital laceration, and then you can see this sort of frontal ecchymosis here. And in somebody, especially if they're altered, this is somebody where you want to be aggressive early with oxygenation and restoration of normal blood pressure. So this is the scan. When we go back to thinking about, what we looked at initially on the first slide and the example, she has, this is all acute blood. This is a new subdural hemorrhage. The reason it's pushing in is that there is so much blood here, the brain is starting to push. Even though this is a lower pressure injury, than an epidural, there is so much volume here, and you have a non-compressible fluid and a compressible brain. That's the Monroe-Kelly doctrine, that
basically you have a closed fixed volume with the skull. The things that can alter in size or dimension are not the blood. Blood is a non-compressible fluid. So the brain can squish, blood vessels can change. This cerebrospinous fluid can change, its pathway, or like whether or not it's offloaded. And so the body reacts in order to try to maintain that normal balance. It's called auto regulation. But in this case, all of that was overwhelmed, and it's certainly possible that that blood pressure 180 that was seen in the field was related to the fact that she was herniating. But this is what old blood looks like. So it's possible that this was from the prior injury and it had not resorbed yet. Can't really say for sure. That workup and that care was done at another facility. But you can see that there is 2.1 centimeters midline shift. This is the middle. This is the middle of ventricles here. And the right ventricle is getting smushed where we're talking about effacement. And then when we come over to this side, you can see the midbrain here. This is the pons and medulla, and they are lighting up with new blood here. And then you can also see, this is what subarachnoid hemorrhage looks like. It's these little white kind of ghost looking things that kind of go along the lines of the gyri of the brain. So that's an example of a subdural midline shift, subarachnoid hemorrhage here, and then midbrain hemorrhage there. Even though, well, we'll get to the hospital, of course. So the patient was stabilized in trauma bay, transferred to surgical ICU. Emergent neurosurgery evaluation was performed, and the injury was not amenable to operative intervention, and it was deemed non-survivable given her poor neurologic exam, both in the field and, it never really improved. Sometimes you'll get a patient that's stunned initially, but their GCS improves en route. I imagine a lot of you have had that experience, and that typically bodes well. Folks that get worse en route, that's more ominous, but even so, it's really the initial GCS post-injury that is the landmark and the jumping off point for the whole rest of the patient's trajectory. And if you ask a neurosurgeon which they'd rather operate on, reversed Eliquis or Plavix, they will say reversed Eliquis, or even just Eliquis without reversal. 10 times out of 10, Plavix inhibits the platelets for about 5 days. There are reversal agents that are not really 100% effective, and unfortunately, when you have something that begins at this level with the GCS of 3 and fixed dilated pupils, there isn't really a role or a ability to salvage that or make that better. And so that was the neurosurgeon's assessment and conclusion, based on, it was also unclear how long from the injury she'd been there. So maybe had she been found earlier, she could have had a shot. Anyway, but we were able to contact her son and bring him to the ICU to be with her, explain what had happened, kind of and have those discussions, and he was able to be with her and say goodbye when they proceeded to comfort measures only care. And I do want to say that is that really matters. I think it can probably feel as if, well, we did all this stuff for this patient and we worked super hard and we got them there, and then all they did was declare comfort measures. But truth of the matter is, that is so important for the families to have that time and to really be able to really understand what happened, to be supported through that. So it wasn't wasted effort at all. And so I just wanted to show appreciation and just commend the folks who took care of this lady in the field. and in her memory, kind of, hopefully we learned something from um, the pictures and going through the case. Case two. So,
So Eric, there was a quick question in the chat,
sure. Yeah, yeah.
about, so what makes normal saline a better choice versus lactated bringers? I think you spoke to that a little bit, but maybe just a
Okay.
little bit more on that topic.
So it's normal saline may not lower the serum sodium. I think there's a common misconception in medicine that if you give a lot of NS, you'll raise the sodium and the chloride. That's actually not the case with isotonic fluids. With normal saline, unfortunately, the pH is 5.5, so it's an acidotic fluid to start with, and which is never good for a trauma patient. That's actually why we've moved away from normal saline resuscitation and trauma, because they're already acidotic if they're in a polytrauma. But the reason why neither one is really going to harm or hurt is that they're both isotonic. And in the time frame that you have between getting here, that it really doesn't matter which fluid's given. When they get here, we institute hypertonic saline therapy, where we're driving their sodium with concentrate, like 2 or 3% boluses up to 150 and over. And the point of that therapy is to create a gradient so that the fluid that's in the brain is pulled back across the blood-brain barrier into the bloodstream. So what we're doing is we're salting the blood to draw fluid off the brain. And it's actually really pretty amazing what a 3% bolus will do. We'll give them 503% quickly, and we can even get a pupil that's fixed and dilated to close back down. It can be really a really kind of amazing effect that it can have. And in fact, it's been shown to be non-inferior to, or that there is no benefit really to mannitol over 3%. The only time we're really giving mannitol now is if we've already pushed the sodium to like 155 and there's not any more room to go, and we're still having we still think we might be able to address the osmotic gradient. But the basics of this is that you want salty blood. Normal saline won't make the blood salty, but nor will it hurt in the time frame that we're talking about. The goal in the pre-hospital setting is to restore normal tension, because what matters most is that we're actually perfusing the brain. Just going back to that slide where we're talking about how if you have one episode of systolic blood pressure less than 90, you've now got an increased mortality risk by a factor of 2.
And I think that's the person who asked the question said that they appreciate that breakdown. So I think that's a great, great information.
Yeah. If you have a question and I don't answer it well enough, please feel free to keep asking the question until I give you an answer that works. But yeah, that's how we think about it in the ICU. And you can kind of see, like, already from this discussion we're having, that this really there's field critical care that turns into critical care in the hospital, but the basic things that we're trying to influence and change are exactly the same. It's just we've got different tools here. And honestly, if there's a one theme from the lecture that I want to drive home, is that care for traumatic brain injury, especially, I mean, all trauma is this way, but especially traumatic brain injury, we are literally on the same continuum, taking care of the exact same thing. It's just you're getting there first, and then you're carrying the ball to us, and then we continue to carry the same ball. It is all about oxygenation and perfusion, and the ways that we have at our disposal to influence those two factors. And that is really where the thrust of research is, and there's some exciting things that are developing, but we still don't have definitive answers. I think I do want to say also, like, the brain is a mystery. The human brain is a mystery. And there are so many things we don't even know we don't know about the brain. But, in the sort of like way that we've come in the last, 20 or so years, we have become more sophisticated. We have kind of figured out at least this much, that it is perfusion, it is oxygenation that can save a brain or help a brain recover, support a brain while it comes back or not. So this next case is a little more is a little more inspiring. So this is a young adult male. He's on unhelmeted motorcycle crash. He was ejected off his dirt bike or motorcycle, whatever it was exactly. Kind of unclear from the sheet, but it was something. And he shot off it and hit his head. He was found unresponsive about 30 feet away from the motorcycle. So he was initially stunned. There was no response at all. As they're examining him, their field GCS, and this did not improve en route, was he wasn't opening his eyes. He was withdrawing from pain. He was making incomprehensible sounds. So he was a 7, and we know that places us squarely in the severe category. And at this situation, they need some sort of airway assistance usually when we're 8 or less. There's an old saying, if GCS 8 or less, intubate. They did not have the ability to do that, at least not at that time, but they were able to oxygenate him with an MPA and assisted respirations, and they got him rapidly transported to the nearest ED. There, he was promptly intubated and stabilized. He was more severely injured, obviously, at a more significant mechanism. He had all of these injuries here. He had, in addition to the brain injury and the skull fractures, he had a open left femur fracture from which he'd lost a fair amount of blood and was really pretty acidotic when he showed up to the hospital that he presented to. But they rapidly resuscitated him, stabilized him, got him to us, because once they had him imaged, they found a really significant epidural with midline shift. And in a young guy, with this time frame from the injury, you got a really good shot at a young guy or gal, I should say. You got a really good shot at saving this patient, at getting them a good functional outcome. And so they called us, and we mobilized with neurosurgery, and we got him to the OR as quickly as we could. So here's his initial scan. You can see this is the epidural hematoma. It's pushing in against the left frontal lobe here. You can also see these little black spots here, that's air from the fractured temporal bone. He had bilateral temporal bone on the left side. He had hemotympany. He had blood kind of under the eardrum, and you can even see little specks here and there of hemorrhage. And these can be pretty ominous, because when you have small little either subarachnoid or intraparenchymal hemorrhages like this, you have to assume that there's some level of diffuse axonal injury. Although you can't really make that diagnosis off a CT immediately after the injury, you have to wait and get an MRI. But you can have patients that initially look okay, and then the brain swelling happens and the diffuse axonal injury kind of presents itself, and then those folks can be in a coma for forever in some cases. But thankfully not the case with him. He was rapidly decompressed, and so again, we got an extra-axial bleed. We can actually fix this surgically, and by we I mean the neurosurgeons. Our role for these patients is to stabilize them as rapidly as possible, get them through the OR with neurosurgery, and then take care of them afterwards. And I'll talk a little bit about what we do in the ICU for these folks. As you can kind of see here, there's a little bright spot here, and that's monitoring that's a bolt, we call it. And then what that does is that monitors the intracranial pressure, or ICP. And that is really a mainstay and one of the main ways we implement the boost protocol when patients are here. And so that's sort of, that's an example of an extraaxial bleed, an epidural that's reversible. You can see pneumocephalus and those things from the initial operation. So his hospital course went this way. He went straight to the OR for left-sided hemicardiectomy, evacuation of epidural hematoma and the subdural. And he had a right frontal ICP bolt monitor placed. He was transferred to the surgical ICU where his neurocritical care was managed by the trauma critical care team by the BOOST trial protocol. I'll talk about that here in a sec. He recovered from his injuries and was actually discharged to an acute rehab facility a month after admission, which is pretty great outcome. Just for his initial hospital course, and I'll talk a little bit more about his 6-month follow-up. So what is the BOOST trial? What is the BOOST protocol? BOOST stands for Brain Tissue Oxygenation Optimization in Severe TBI. It's a mouthful. And it's now in sort of its third phase. There are 10 centers participating in a study that's going to be a little bit more than 1,000 patients. And what they're looking at is there improved outcomes in folks that not only their intracranial pressure is managed, but also their oxygenation, brain tissue oxygenation, or PbTO2. But how do we get from central perfusion pressure to oxygen delivery? And it really has to do with cardiac output and mean arterial pressure. So in the ICU, we work to manage and tightly control central perfusion pressure, kind of as a surrogate for if you're perfusing the brain and you have a hemoglobin around, but around at least above 7, but around 8, then you can assume that you've optimized your oxygen delivery component, which is this equation here, that takes into account hemoglobin, cardiac output, and then oxygen saturation here. You'll notice that the partial pressure of oxygen in the blood gas doesn't really contribute a whole lot because this is just an additive to a 0.003 times that number. But why we focus on 90% sat is that's this number here. So this equation takes into account hemoglobin, cardiac output, and how much oxygen you're giving them, and it really describes the delivery to the tissue. And then our way to monitor that and actually control that is central perfusion pressure. So mean arterial pressure and is central perfusion pressure is the mean arterial pressure minus intracranial pressure. So where this can get tricky is you want to balance these two things. You want this less than 22 and you want this around 70. So those targets can sometimes fight one another. And so it's always a question of how do I maintain that balance in this patient. And there are tiered interventions that we use in the ICU in order to maintain that balance. The BOOST trial collects data for 5 days, but we maintain them on aggressive monitoring and management well past that time in order to give the brain the most, give it the best possible chance to recover. So what do we do with this stuff? Well, so these are the tiered neurocritical care interventions that we do. So we start with tier 1. If they work, then we stay on tier 1. So these things that we do, and again, this gets back to like things that you all are doing in the field, adjust the head to lower ICP. So that's why in your protocol, it says, if possible, you want to get that head up 30 degrees because you are in effect controlling their intracranial pressure. We're the ones we're lucky enough to have a way to measure this in the hospital. We have the neurosurgeon puts a bolt in, but the actions are exactly the same. You want to elevate the head to your and other things. We'll drain CSF fluid if we have an external ventricular device in place. We can optimize CPP to a max 70 millimeters mercury with fluid boluses or vasopressors. So that's exactly the same thing that y'all are doing in the field. If it's life flight, they may add norepinephrine to volume. If you have that ability, but otherwise, that fluid volume that you're giving is doing this exact thing. You're working to push. When you push the mean arterial pressure, if you go back to this equation here, if you're increasing this is directly proportional to central perfusion pressure. So these are relationships, right? So CPP is inversely proportional to ICP, which makes sense. If you increase the pressure inside the skull, it's a lot harder to perfuse it. But if you are able to increase the mean arterial pressure, then you're going to be perfusing more. And that's really the crux of everything. This is what you all are doing in the field, and this is what we continue here in the ICU. We generally err more on this, or we generally use more hypertonic saline. That's what HES stands for, and we'll use 3% boluses. We know that a continuous drip of 3% really isn't going to influence or get you the physiologic result that you're looking for. Mannitol is generally held in reserve, but we'll drive a sodium as high as 160. We know that above that there's problems that can start developing, and that you're outside the kind of window where that can actually have a therapeutic effect. In general, all of these folks with severe brain injuries are going to be on some sort of seizure prophylaxis, because we know that seizures increase the metabolic demand of the brain tissue. And when you have recovering brain tissue and you do that, it really can negatively impact the ability for that brain to recover. We'll go with higher doses if we've been going about 60 minutes in and we've failed all the tier 1. There's a repeat scan, and if there's something that can be done surgically, it'll be readdressed at this time. We'll cool them. We will push them into a profound kind of sedated state and trial neuromuscular blockade. Trying again to optimize CPP as the surrogate for oxygen delivery. So central perfusion pressure is the surrogate for oxygen delivery to recovering an injured brain. We'll keep our PCO2 still normal, but on the lower, we're working with the normal pH, but we may push a little bit down toward the low normal side of the PaCO2. But again, really hyperventilating somebody, we're not really doing that unless we're going to the OR. And then tier 3 is if 1 and 2 have failed, probably the first thing we'll do is a pentobarbital coma. In a patient that has not had an operation yet, say they have DAI or something else, we'll discuss decompressive craniectomy. And again, we'll cool to an even lower state. And that's the gist of what we're doing in the ICU. But aside from the cooling and having vasopressors at our disposal and having hypertonic saline, the same principles apply here. That as to what you all are doing in the field, and I just think that's kind of a really cool thing to think about. That it's really, we're doing exactly the same thing that you all are doing. It's just that we've got other tools, but it's all along the same continuum. This is just a kind of schematic to talk about the things that we do, and it's the guy that wrote this article called it the mantle. But these are all the ways we can influence and sort of support a healing brain. But I'd already kind of gone through that with the tiered approach. And so this is sort of the latest iteration of the BOOST trial, which again is a multi-center blinded endpoint comparative effectiveness study of brain tissue oxygenation and ICP pressure. And so what they're trying to prove with BOOST 3 is if we maintain oxygenation and ICP, are the outcomes better, as opposed to just intracranial pressure monitoring and targeting. And so the goals here were to maintain the ICP less than 22, and then the brain tissue oxygenation of greater than 20 at all times. There's different ways to measure this, but we're measuring it without the use of a Lycox monitor, which is how we used to do it in California. But basically, there are ways to extract from the CPP data how well you're oxygenating. But again, this all boils down to oxygenation and CPP. Primary outcome is the Glasgow outcome scale extended performed at 180, or basically 6 months by a blinded central examiner. Favorable outcomes defined as sliding dichotomy or definition is favorable and severity is defined. So basically what they're saying is like if it was a really bad injury and they improve significantly, that favorable outcome is equivalent to somebody with a less severe injury that also had a good outcome. But really the punchline is this. So Dr. Teresa May, and I'll show a picture of her in a sec. She is she's the principal investigator here for the Boost trial. So she sent us a message about this patient just the other day, actually. At 180 days, which is the 6-month Boost follow-up time period, the patient's telling jokes and doing all the things he was doing before, and his grandmother and sisters are very happy to have him back. I just really wanted to share this, not only for the crews that took care of her or him, I'm sorry, but also just as an example of what the work you guys do, what it can do for patients and their families, and that you begin something that is just really kind of amazing when you think about the just it begins with oxygen with the crew at the patient's, the injured patient side in the field, working to oxygenate and perfuse somebody. So anyway, just a thank you, I guess. And then, so this is also like, if you happen to see these folks around or are curious to read a little bit more about our participation in the Boost 3 trial, this is Dr. May up here, and this is Dr. Foreman. He is one of the neurosurgeons, and she is a neurocritical care intensivist that works alongside with the trauma critical care group when we have somebody on the Boost trial. In general, even if we don't have a pressure monitor in the patient and we're not enrolled in a trial, we generally do all of those tiered interventions for all severely injured brain, all severely injured traumatic brain injuries. Anyway, thank you, in your partnership for all of this, and yeah, just having it's nice to share an outcome like this. So any questions? Anything I can clarify?
So far, none in the chat. Oh, here we go. Is it still appropriate to hyperventilate if your goal is nitrogen washout for intubation prep?
Interesting question. That's a really interesting question. I think you're in a position there, I think, where you're considering like, if you don't do that, you got a really good shot at having a hypoxic episode, right? So in that case, yeah, like if you're preparing to intubate this patient in the field and you don't want them to have, a hypoxic episode after the intubation, then yeah, it's reasonable for a short period of time to do that. The point of the changing the protocol, and the point of like really spelling that out in the protocol is to say that, like, people were routinely hyperventilating all brain injured patients. And so it's to dispel the notion that that's helpful. And so continued hyperventilation not indicated. Nitrogen washout before you intubate to help somebody maintain their oxygen level through and after the intubation. Yes. Does that make sense?
I think it does. I did have a question from Tammy. Any suggestions for our BLS services who can't intubate and use advanced airways in remote airways to better support TBI patients where they may not have access to IV or other?
Yeah. So that's where that's the crux. You're out in the woods with somebody that just ran into a tree with their snowmobile, and you've got none of the things that you need to. At least you don't have any advanced means of dealing with the airway. I think in that first case, we talked about a nasoprotective airway. There's several of these cases I've reviewed where that's been effective in getting past either a clenched jaw or something else to allow you to give rescue breaths to a patient that's obtunded. Oral protective airway if their jaw isn't clenched. Really, any way you can deliver oxygen into the patient. But if that's all you have, then that's what you do. I suppose if neither one of those are working, then the next move is a crike. In the field, a cricothyroidotomy. And I know we trained on some of this stuff at the EMS conference. So hopefully that training is you guys are remembering some of that. And hopefully we'll have more training opportunities for that type of thing. But yeah, in the field, if you have no advanced airway and you need one, then a cricothyroidotomy is the answer, unfortunately.
Excellent. Well, I don't have any further questions in the chat for you.
Well, anyway, thank you all very much for your time. I love being able to talk with y'all and share these outcomes. And again, if you have questions about patients, just have your chiefs holler. All right, take care.
Have a great day.
See you.